On this episode of the ASC Podcast with John Goehle, recorded live at the New Jersey Association of Ambulatory Surgery Centers annual conference at the Palace at Somerset Park in Somerset, New Jersey, we interview some of the speakers and discuss the benefits of membership in the association.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsor, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 222 of the ASC Podcast with John Goehle for May 23rd, 2024, recorded at the New Jersey Association of Ambulatory Surgery Centers annual conference at the Palace at Somerset Park in Somerset, New Jersey. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We'd like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it's important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. And joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
So this was the annual conference for the New Jersey Association. We attend actually all four of the conferences throughout the year, and we had a lot of fun. I should say we, but it was actually me, Sue.
Yes.
You were not able to join me. I was there with Tony Lyons, my dear friend and one of our financial consultants at Ambulatory Healthcare Strategies. And Sue, I told you the night before the actual event kicked off, we had trivia night. This is the second time they've done this, and this is a ball. We really had so much fun. Now, last year, we put together our own team, but this year we had to have a random team. So they
worked.
And it did. So my team won. But I do have to point out, Sue, that it was an all-male team, and it was all vendors that were participating in it. And we just had a lot of fun. It was very different than last year, but we were very excited and surprised when we won, because there's a lot of strategy, by the way, involved in here, because you can lose points as quickly as you can gain them. But I think that's something that really is a good draw for people that are there the night before. So the conference was good. We had a lot of great speakers. I was only able to interview, I think, 4 or 5 speakers during the conference, but the speakers that I was able to interview did a great job. Yeah. I was not able to interview any of the board members, unfortunately, or even the staff there, so I don't have anybody to talk about membership. So I did want to just mention again that we really want to we always encourage all of our listeners to join their state associations, and if possible, and if they can afford it, to join the ASC Association also. But state membership is particularly important to be able to participate in all the activities that these state associations work so hard to present. So membership, and I will provide a link in our show notes here, but a membership, facility membership, is very reasonable, $1,600 per year. And this is what they say in the website. We are the voice of our members in Trenton, which is the capital of New Jersey, and influence public policy that pertains to ASCs. They also noted that they have networking opportunities within the ASC industry, both at their meetings and through contacts through membership. They share their legislative intel and routinely update its members on what's going on the legislature. They serve as the industry voice on behalf of its members with the media and within the communities they serve. They have a very strong working relationship with and access to state agencies affiliated with healthcare. They also serve as a liaison to the accrediting agencies, and they are the go-to source for compliance issues. And indeed, I think at least once a week I get questions from members from the New Jersey Association. As much as I can answer them on a timely basis, I'm able to do that. They also provide ongoing education for their members, employers, and the public in general. And they do support the ASC Association by representing New Jersey by giving input to the needs of their state. And they also have the support of the largest healthcare law practice in New Jersey. So again, I really do encourage all ASCs in the state of New Jersey to become members. And again, I'll provide a link to that. For those vendors out there that are listening, I do want to point out that vendor membership is also very reasonable. It's $2,500 a year, and you're showcased at 3 membership meetings. You're able to exhibit at the annual meeting for a reduced rate, and you're also listed on the New Jersey Association website. And you don't have to actually log into the website to be able to see your membership there. So again, in the show notes, I'll provide links to membership information. So we're going to start all of our interviews with Bonnie Lavoie. She was the program chair for the State Association meeting. Bonnie is a good friend of ours, a long-term friend of mine over the years, and let's listen to her interview. So I'm here at the 14th Annual New Jersey State Association Conference at the beautiful Palace at Somerset Park here in Somerset, New Jersey. It is May of 2024, and this is your annual conference, Bonnie. And you and I have been together a long time. I've been attending your conferences for more years than I care to remember right now. But a beautiful site, beautiful conference. Bonnie, you and I have been friends for a while. You got me involved in the New Jersey Association, and I appreciate the support that you've had for our company, as well as bringing me in to come. People still bring me back. I don't know why they do that.
They love you. They love you. You are a very sought after speaker. When I first reached out to you many years ago about coming to the conference, I wasn't sure I could even get you. So, and I really, at the meetings, I would say, we got John Goehle coming, and everyone was so excited. Yeah. So you're a great speaker, and we hope to have you every year.
Your audience was fantastic. I did a speech earlier today on benchmarking, and it was interesting. So here's the interesting thing, Bonnie. I asked how many people had heard me speak about benchmarking before. Half the audience did. So, I had to quickly revise what I was going to talk about to make sure that I took a different bent. Yeah. So, but that's the nice thing, is that, you got to really active participate. A lot of good questions occurred during it. Good. And so, first of all, introduce yourself to our audience who might not know you.
I am Bonnie Lavoie. I am a nurse by trade, an OR nurse. I've been in this business since 1998. I'm currently working as a consultant with Ambulatory Consulting. Yep. This is fairly new for me, but I've been a consultant before. Right. So, and I've been on the board of directors here at NJAASC for 14 years. Yeah. I think this is the first year I'm not on it. I thought I was retiring. Looks like I didn't.
Yeah, so that never happens. I know. I kind of figure that's going to happen with me in a couple of years. So
yeah, I'm back.
So, and your relationship with the conference here?
Well, this was my brainchild years ago. Right. We were looking for a little bit of a fundraiser, and I took it upon myself very much by myself with another board member, and we had something down in New Brunswick, and we were so excited we made $5,000. Yeah. We thought we'd go in the red, but we made $5,000. Yeah. We literally did everything ourselves. We did things with posters and magic markers. Yeah. When I see the growth in 15 years, it's like unbelievable. I mean, we have a management company called Success, right? And they've been wonderful as far as helping me get it organized. We have monthly meetings. Yeah. We've had weekly meetings, and it's been good. It's been good because we're all busy, and I need an extra hand. And I'll tell you, I've gotten lots of good comments so far at this conference. There's a lot of topics that are timely for especially new DONs, which I'm running into a lot as a consultant. Right. A lot of new blood out there. A lot of people are leaving, and then the new blood coming up. It's very, very interesting to see what they don't know, what we take for granted. We think they know it, but they really don't. So it's nice to come here and sit down, have some nice food, and networking is key. To me, that's the key.
you bring up something important. Our Director of Nursing Boot Camp is next week.
Yes.
It is our biggest boot camp ever. And when we started it during the pandemic, we were working heavily with New Jersey during the pandemic, of course. But we started during the pandemic, or just shortly after the pandemic. And we thought it was going to die away. We thought that nobody, and now we've got the largest boot camp ever because, to your point, there are new nurses coming into it that are just not, that just need more experience, need that network, and that's what this conference is all about.
It is. Even to mentor a new DON, I'm starting at a different level because I've done this for so long.
Yeah.
When I realize they don't even know the very base part of it, I see why these conferences and your boot camp are so important.
Right.
And they're with other people of the same mindset. So they don't feel like dumb. I hate to say that, but I always say, I don't want to be condescending. Let me know if you know this.
That's right.
Because I don't want to be like that. But they don't. And to be with like people, it's good.
And you're correct. We're seeing a lot of, I think in the years past, we come to these conferences, see the same faces every year.
Yes.
That's not happening now. I see a lot of new faces out there. Exactly. So I think there's, we have a bunch of people that listen to the podcast. Some are vendors. Yeah. So let's start with the vendors because I want to tell you the vendor experience this morning was fantastic. I walk in, I'm met by one of the board members. She told me exactly where to go. Not like my wife tells me where to go, but it was very kind.
Yeah.
And we were set up in no time flat. You guys have been absolutely fantastic. So the vendor experience is good. There's a good flow. And I'll tell you, one thing that was interesting is last night you had the trivia night. It's the second year in a row.
Yes.
And last year we did not make the top 3. This year my team won.
You cheated.
As you know.
You cheated.
So we
the Coneheads.
The Coneheads.
The Coneheads won.
And they were all male.
It was all male.
And they were all vendors. They were all vendors.
Yeah.
Which was kind of funny in itself. But it was, we had a ball. And I stayed there the whole time. And what was nice about it was a random. So the people that we were set with were random, which is a good way to kind of force people to network with people or just to, show themselves around. So I got to meet a lot of new people yesterday. And so from a vendor experience, that was very good because it just sounds wrong. You're kind of forced to get out of your booth and go around and talk to people and have a ball at the same time.
Well, what's funny is I went to a couple of different things about like how do you start a party and how do you get people motivated to network, and they would give you like a puzzle piece and how to meet another puzzle piece. So and it forces you to talk with other people. So last year was our first time doing trivia, and we noted that people were clanning together. And some tables had 10 of all the same people, and some had 4. And it's not inclusive. It's like, so this year we said, let's try something different. Yeah. I suggested giving everyone like a different color crayon or something. Yeah. So then they came up with giving each other, stamps. Yeah. And it worked great. Everyone had to talk with each other. I met 3 new friends, and we were laughing and talking. And today I saw them at the table, and we were hugging, and it was like, oh, old friend. I think the vendors like that. Yeah. It gives them a chance to be personal and not just be that guy behind the desk.
Exactly. And that's something, I attend a lot of state associations, probably average 10, 15 a year. And that's one thing that's very different here is there's a lot more interaction. And the booths are great. The setup is good. You force them to come, the people, it's not going to sound good to the attendees, but you give them an incentive to go to the booths, and we have a good interaction. It's a short interaction, but that's fine. Often that's all you need.
Oh, I meant to mention, too, on our board, we have a vendor member.
Right.
We have people, because we appreciate their comments. Yeah. Like after this, I go around and ask everyone, are you having enough traffic? Yeah. What's going on? Some spaces are better than others. We'll close them out next year.
Right.
But to me, the networking, besides the education, the networking, the value is so important. Yeah. When I'm looking for a service or product, I actually go to NJAASC and I pick from that. Oh, here's this guy. And I remember them. Oh, he was on my team last year. Yeah. He was a pharmacist. I'm going to call him. Yeah. So you make those little connections, and it really carries a long way.
And there was a lot of deal making going on between. So the vendors have. It seems to be a little more conducive to vendor interaction here too.
I think so.
So let's talk about the other part. The kind of the important thing for our members and our listeners. And so I know that I know a lot of people that attended. Are listening to some of our recaps. Is kind of a good way to kind of get a 10 or 15 minute recap of some of the major speeches here. But we also know that there's a lot of people that have never come to the conference, and let's face it, sometimes you might not be able to get out. But I just want to talk a little bit about the value of these conferences and what makes you different, because there's one thing that's very different about your conference process. You have more conferences than any of the other state associations. So talk a little bit about this.
Well, this is the major conference.
Right.
And then we have quarterly meetings that have turned into mini conferences.
Right.
It never used to be that way. It was, a little bit of a business deal and maybe a speaker.
Yeah.
They've now turned into mini conferences. So this conference, I have to take it up a notch.
Right.
I try not to have the same speakers. I try to do it. And we also bring in just what we just had, the Ask the Experts, which I think is huge. Have Department of Health, our legal counsel, our lobbyists, and the questions from the audience. I saw people writing down all these answers because they're not comfortable reaching out to these people. Yeah. So I think that's very worthwhile.
Yeah, and that's one way for you to get an answer or have somebody else ask the question for you from the Department of Health, right from the source there, which in New Jersey in particular is challenging. I mean, every state has their own issues.
Well, today, funny, we were sitting in the front talking about everyone's been having surveys lately. I guess we're all due. Yeah. And we're talking about the dumbest things we had to do. And, did you see this? Did you see, I had to do this. I had to do that. You have a policy on that? Can you share it? It turned into like a little fact-finding mission where we were just laughing about the crazy things that had happened. Yeah. So that networking really can work out for policy process. Yeah. Sometimes you don't feel so bad. Like, my survey was terrible. Oh, mine was too. Yeah, so it's the misery loves company and then also the helping each other, which I really like.
And developing a relationship with somebody that you can call. Yeah. And I did a session on benchmarking. At one point, I actually didn't say during the session. So those of you that are listening now, and I ran out of time because you never give me the 7 hours I asked for.
I know.
But one thing that I kind of emphasize often is that benchmarking doesn't need to be this complex process. It could be simply, you connecting with an administrator at another surgery center and getting their statistics and comparing yourselves with each other. That's benchmarking. That's external benchmarking. So that's very viable.
We have a benchmarking committee in New Jersey, and we will be working on some more benchmarking next year. I want to be on that committee next year. I've noticed as a consultant now, I'm seeing what centers are missing, and a lot of that is New Jersey benchmarking. Yeah. I'd like to see what our infection rate is. I'd like to see a couple other things. So maybe we can expand on that.
That's fascinating. It's totally off topic right now, but I'm on the quality committee, which is actually the benchmarking committee for New York.
Okay.
And it would be interesting to have our two committees, talk periodically just to have some ideas. I think it'd be because we're struggling too. It's tough because this is, you don't have a lot of administrative support behind it. Right. So it would be, let's talk about that offline.
Consider that done. Yeah.
Absolutely. Bonnie, as always, it's great. Yes. When's our next conference or our next meeting?
What's today? I think they're having one in July, believe it or not.
They are.
And it's basically more of a business meeting and a tie-up because we have new board members this year, and they kind of do their own boot camp, a board boot camp.
And it's going to be at the country club.
Yeah. So it'll be fun.
It's at?
The Galloping Hill, right?
Yeah.
Galloping Hill.
And it's going to be at the Galloping Hill Country Club, which is a beautiful location.
Yeah, I want to say something too. We changed the venue for the hotel from last year, and that place is great.
Oh, it was nice.
When you walk into this big, beautiful, everyone was sitting around talking, sitting at tables. I mean, even before we started the event, people were chatting and hanging out together, and I liked that. So we'll probably do the same thing next year.
That was a great idea.
This place is great too.
Yeah, it was nice. So this year you did something different. You had the trivia night over at the hotel instead of here on site, which was nice because it was easier for people to get to. And then they had the opportunity afterwards to go to the bar. Right. I missed it because I actually had to work afterwards, but I know that there was a lot of drinking and a lot of fun going on. So
I went in there and someone said, "Do you want to sit down and have a drink?" And I said, "If I do that, I'm not going to get upstairs." I went to bed. I went upstairs.
There's a lot of party animals among this crowd.
There are.
Well, as always, Bonnie, it's been a pleasure. Thank you.
It's been great being your friend. Okay.
And next, John spoke with John Karwoski of JDJ Consulting. His talk was titled, "Are You Upside Down on Your Drug Expenses?"
So John is a frequent speaker in our podcast here and a good friend of ours. He's also one of the pharmacy consultants that we work with extensively at Ambulatory Healthcare Strategies. And Sue, what I found interesting this time is we spend so much time talking about drug documentation and talking about drug diversion. And I think that's been the focus of many of our conversations over the years. It was kind of nice, though sad, that we had to talk about expenses in the pharmacy industry here.
Yeah, but I think you wanted to present something a little bit different. It was pretty interesting.
So let's listen to that interview. I'm here at the 2024 annual New Jersey State Association meeting in Somerset, New Jersey. And I'm here with my friend, John Kowalski. He's with JDJ Consulting and one of our recommended pharmacy consultants for our centers in the tri-state area in particular. You are all over the country. John, introduce yourself and your company.
Hi, John. Yes, John Kowalski with JDJ. I'm the president and founder. I formed JDJ after leaving a director of pharmacy position in Philadelphia to start this company in 2001. We've grown through the Mid-Atlantic states and currently probably one of the only consultant pharmacy services throughout the country, from California to Florida to New York and everywhere in between. We really like helping centers, whether they're de novo or ongoing or conversion from hospital to surgery centers, on drug safety, regulatory compliance, and cost avoidance.
What I loved about your speech this time is let's put it this way. I think you and I are both tired of talking about drug diversion. We have to talk about it, but we've spent a lot of time talking about it. And we talk about, compliance with regulations. This time you did a speech on pricing and costs. So I thought that would be, I don't think we've ever talked about it on the podcast. So talk a little bit about what you discussed during your conference and anything you have to say about financing drugs.
I was very excited when asked to do the talk, and I knew this talk was what I wanted to do. Cost analysis of drug expenditures in our ASCs. Since 2016, JDJ Consulting's been completing an annual benchmarking study on drug costs in surgery centers, with a few additional questions on new formulary additions, new types of surgical procedures related to drug expenses. And I was able to present that today in a graph fashion that demonstrated what certain drugs used in surgery centers have done since 2016 to the current time. We'll do it again this year as another benchmarking study. And secondly, I've looked at some drugs that were new over that time period, new FDA drugs that were added to formularies in surgery centers. And it was quite interesting with a drug like Exparel. About 50% of centers have added it. IV Tylenol, another drug that was questionable on whether we should add it due to the expense. So I looked at those types of things. We also looked at GI centers and how to manage their drugs, and cataract centers and who's using some compounded intracameral injectable medications. So I think it was really a take-home message for our managers to take a look at their drug formulary. And it always starts with what drugs are approved for your patients in that center. And finally, look at how you're managing your inventory. The talk that you gave this morning was tremendous on the 80-20 rule, or 80% of your costs come from the top 20% of the drugs you buy. And can we inventory turn those drugs over and over so we don't have cash sitting on the shelf? Right. Exact message you had with the financials is what I shared with the pharmaceutical costs.
So, John, you brought up something that I think is important to remind our listeners here, is that you do this cost study on an annual basis for your clients. And you also mentioned benchmarking, which is near and dear to me. That type of a study can definitely be used not only to demonstrate compliance with your external benchmarking requirements, but as I talked about quite a bit, as identifying opportunities for identifying ways to cut costs, et cetera.
Yeah. You hit it on the head there with, the requirements for benchmarking for an ASC. Some of my centers have actually used our benchmarking study for their AAAHC surveyor, and very well received. And we've done the work. We're doing the work for our clients because we see the value that it could give them. Right. In not having to take them away from the care of their patients. So it's really been a win-win with what we've done over the years. And you're right, I don't know of many other pharmacy consultants that are looking at the data, the benchmarking data that we've collected for these number of years. I learned this when I was a director of pharmacy in Philadelphia at a hospital, where we looked at drug costs annually through our national organization. And we at JDJ are kind of doing the same things for our surgery centers.
So where do you think drug costs are going right now in the industry, and what's driving some of these prices that we're seeing?
Number one, new FDA-approved drugs are expensive. And they are marketed heavily by a strong sales force to surgeons. Yeah. If we cannot control that, the surgery centers cannot afford these new expenses. Even though it's a pass-through in some respects, they don't know when and how to manage it. And surgeons just want. Yeah. So my feelings is an expert pharmacist or someone that can research the data-driven usage of new drugs and put it in a position where we know the drug might be needed for some people, but not every person needs it. And other than that, our generic drugs aren't really moving much. Our data showed us for the last 8 years, John, that we see a little bit of peaks and valleys, but if you're not part of a GPO, you're not taking advantage of the cost savings, so that's number one. Your generic drugs are going to be generic drugs, manage the inventory and not have cash on your shelf. But the new drugs being approved by the FDA, particularly in ophthalmology, orthopedics, your pharmacist needs to be on the table as a decision maker with the physicians.
And keeping control, making sure everybody knows the ramifications of this. You did mention that some are pass-throughs, but let's face it, a lot of the drugs that are under this pressure are not pass-through. And many people in the organization don't even know the pass-through drugs, or that they don't communicate with the billing department to find out what they can get passed through. Or, I'm sorry to say it, sometimes the doctors are given misinformation by the drug reps as to what you can get reimbursed for.
It's a sticky world that we put a nursing director in the middle of.
Yeah.
And they've never been trained with this. I mean, I was a chairman of the P&T committee at a hospital for a number of years. It's a complex way to evaluate drugs utilization in a facility, both from an efficacy and a safety and a cost standpoint. I was just talking to a sales rep from the company that makes Exparel in the audience today.
Yeah.
Asking me about, do you know about the reimbursement? Pharmacy's always been a cost center.
Yeah.
All we worried about is how much we spend. Administration and finance and your people can then look at what are we recouping after we send the charges out. But pharmacy, we want to make sure we are not using drugs incorrectly and adding costs to the bottom line of the case.
Right. What do you think the supply chain issues are heading right now? I know that we've been constrained in the past. Is this problem going away anytime soon?
No. It's like in everything. Supply chain is the heart of getting your just-in-time drugs.
Right.
What does that affect? Well, that affects managers and buyers stockpiling because they're worried about the supply chain.
Which exacerbates the problem.
Exactly.
Yeah.
It snowballs the cost because, as you know, John, drugs on your shelf are cash that could have been used somewhere else.
Right.
And we put our purchasing agents in surgery centers in a dangerous position. They can't go to a surgeon Monday morning and say, we're out of it, it didn't show up.
Yeah.
So they take more inventory. If you give them shelves, they're going to fill the shelves up.
Right.
So supply chain is going to be supply chain. We just have to help the buyer and the nursing management team know how to look at the high dollar drugs, the 80-20 list, the reorder points so that we don't run out. I did a nice graph on this thing where this danger point, as you run down the inventory amount, is critical. You can't get into the critical part. But you can't get into the overstock part either because who's going to walk into
the drugs will age out. Yeah.
The CEO is going to knock on your door and say, hey, you're spending this much money and you got this much money on the shelf.
Right, and you risk the drug expiring before you can actually use it.
So I think our buyers are put in a very difficult position in today's world because the supply chain is unpredictable.
Well, and you bring to an important point. I've been a big supporter of pharmacy consultants. Many of the states we work in, pharmacy consultants are required, but that's not always the case. So without selling your service, because it's an excellent service, don't get me wrong, but sell the purpose of a pharmacy consultant for our audience.
And we see the different variations in state requirements. Some centers are still, how many times does the rule say I need you?
Yeah.
They don't see the bigger picture. The bigger picture,
or the value of it. They think of the regulatory requirement, but not the value.
Yes, just the regulatory. I've left managers who, when I've done a visit, found infractions, John. I went to the administrator. She said, well, we just had our accreditation and we had zero deficiencies.
Oh, don't get me started.
Now, I don't like that line because that surveyor doesn't have the eyes for everything.
Right.
And the pharmacist is the best one to say, hey, you're reusing your propofol vials more than one patient.
Right. Because they can look at the records, whereas the average surveyor is not getting into that level
exactly.
of detail.
So I think the value of a consultant pharmacist is our pharmacists are clinical pharmacists out of hospital practice because we're using acute care medications in the surgery center. Mm-hmm. We're not a retail pharmacy consultant group because I couldn't work at a Walgreens because I don't know Walgreens drugs. I don't know the street drugs. I know the hospital drugs. Right. And I can speak to the anesthesiologists and the surgeons where maybe the director of nursing needs that champion to defend the cost of products.
Yeah, and your point's very well taken. I've walked into places where they're using a retail pharmacist for the consultant. They have no clue what's going on. And I watched an interaction with you and one of your clients just before we came up here, where they were asking for an alternative drug. You gave them a great answer. Those are the things that sometimes our clients don't remember that it could be very valuable. One thing that you and I kind of talked about a little bit before, one of our sponsors is MedServ, which makes this wonderful cabinet and for storage of these drugs, and it's a really great alternative to the very expensive option. I mean, we all love Pyxis; it's a great product, but it's too expensive, to be honest, with the average surgery center. Can you talk? I mean, we can mention MedServ; it is a sponsor, but just talk about where we're heading with regard to drug documentation very quickly, because I know the focus is more on price.
We're behind the times in automated dispensing cabinets. Pyxis doesn't do anything for a surgery center. It's way too expensive. It doesn't have the need. MedServ and I stumbled upon each other about 5 years ago. They weren't ready for prime time, and I told them they didn't have enough reporting. Today's units are priced competitively. They're going to be able to give us control of narcotics. But you know what we're using them for now, John? We're using them for tracking expensive drug usage.
Oh, good.
So when a doctor wants Sigamadex, which is expensive, they have to put the patient name in and dispense a vial that's linked to their name as they used it.
Yeah.
And it might be some qualifiers on there. You can't do that when you walk into a med cabinet and a drug's on the shelf.
Right.
You're never going to control drugs expenditures if you don't have automation. I can go and bring up my surgery center's reports on my cloud-based data system right now, wherever I'm at, and tell my nursing director, hey, that Sigamadex usage is starting to sneak up. Let's have a meeting.
Right.
And that's automation, John, and we need it in our surgery centers.
Absolutely. You need to be looking at these products now, if for no other reason to remain compliant, with the pharmacy regulations, for documentation. So I think we're going to be talking a lot more about that over the next year. John, it's always a pleasure talking to you. I'm sure I'm going to see you again soon somewhere, some state, but thanks for your time.
Always great to chat. Stay in touch. Have a great Memorial Day weekend.
You too. And next, I had an opportunity to meet with Nina Dietrich. Her speech was very different. It was on leveraging LinkedIn to build your ASC's brand and yours. And Sue, I know you do a lot of the work for me on LinkedIn, but I learned so much from her, and hopefully I know you listened to the interview already and edited it. So hopefully we'll be able to do a little bit better job of reaching out through LinkedIn. And what I found interesting is I was kind of surprised. I never really thought about LinkedIn as a real tool for surgery centers, and she certainly had a very strong argument for it. So let's listen to that interview. So I'm here at the New Jersey State Association meeting in May of 2024. This is their annual meeting. I'm here with Nina Dietrich. Nina, introduce yourself.
I'm Nina Dietrich. I handle PR for the association. I've been working with the association for quite a few years, and I'm really excited to be here today to talk about LinkedIn.
This is a fascinating topic to me. You and I were talking before we started, and by the way, you just finished a presentation on it here. What was the title of your presentation?
Leveraging LinkedIn for your personal brand and your ASC's brand.
And I was telling you, our story is that we use LinkedIn a lot. I mean,
that's awesome.
Our podcasts are automatically published on LinkedIn. So so as I was telling you, I honestly don't quite know how it works, but because I push a couple buttons and, there's this automation that makes it work.
But you're getting traction there,
right? But
we
do. And our largest number of people, new listeners, we know is coming from LinkedIn, just from,
awesome.
Research we've done. So, so for our listeners here, this is important. This is serious. And then we were also having a conversation about who are our real marketing, who are we really marketing to? But why don't we just start by talking about, the content of your speech and what you were trying to get across to the audience?
So there's 8 billion people that use LinkedIn.
Wow.
Globally. There's 6 million healthcare professionals that go on LinkedIn every week. There's 340,000 groups on LinkedIn.
Yeah.
The thing about LinkedIn is it's free. It's the largest and free networking tool there is right now. And everybody's there, whether it's your patients or it's your referral sources. they're going there, sometimes even before they go to your Ambulatory Surgery Center's website.
Right.
So we talked today about how to build a profile, because you have a brand presence, whether or not you do anything about it or not. So why not take purposeful steps to actually create the kind of profile so people see you the way you want to be seen? And there's, professional reasons, professional development reasons certainly for that. But from the center standpoint, having a page on LinkedIn is important from a recruiting and retention standpoint. It builds employee engagement and morale, and you can be sure that new hires are going to LinkedIn to get a lowdown on what people say about your center and what kinds of values are you imparting in your center. If your team is running a 5K, then you're saying something to a new hire about the people work together, they play together, you care about, charity and giving back. So there's lots of reasons why a center would want to have a page too, not to mention referrals, which is what we spoke about earlier.
Yeah, you bring up something, because we hadn't actually talked about that before this, is you're right. I mean, employees go to LinkedIn a lot. I mean, we get, and we really try to make sure all of our employees at Ambulatory Healthcare Strategies is LinkedIn. Not everybody knows how to do this, and we don't help them, I'm afraid. So I'm learning from you. I got to do a better job. Even though we still have a big presence, there's more that we could do, definitely.
Certainly, and you could. There's lots of guides online about how to build a profile and make the most of it. I think if people schedule it, and that was actually how we concluded the session today, we're such scheduled animals. And if you say, okay, every Thursday while I'm having lunch, I'm going to put in 10 minutes to work LinkedIn, you'll do it. And you'll see how that accumulates. You don't have to invest hours. And I think the more people get on and sort of figure their way around, the more fluent they'll become. It's not hard.
Right. Yeah, and that I've been told. And again, I think the important point is, our audience. You talk to a lot of people. They don't have a lot of time. No. I mean, you're right. They can schedule it, but there are so many stresses that they have right now. Not the least of which is recruiting people, be it the doctors or be it new nursing staff or anybody else, and even your scrub techs, your receptionists, as you said, they're not necessarily ignoring LinkedIn either.
They're not. I mean, professionals at all levels are looking at LinkedIn. And if you're time pressed because you're short-staffed, it's sort of like the chicken or the egg, right? Yeah. If you make time to work LinkedIn, maybe your recruitment and retention processes will improve as well. Certainly as a recruiting tool, people are going there. They want to see who they're going to work with. They want to get the lowdown on how long they've been there, right? So if I'm coming to work with you, I'm looking at your profile to see how long you've been there. Yeah. Are you a new boss, or have you been there for 10 years? Have you job hopped?
Yeah,
right.
That's a good point.
Do I want to work with somebody that has been in a lot of places? Are you fluent in Spanish?
Yeah.
If I am too, that might be something I want to know about it.
Right.
People are looking for sort of the non-resume type of information. I'm going to look and see what kind of endorsements or what we call recommendations on LinkedIn, what people say, what it's like to work with you.
Right.
So today we talked about how do you get those recommendations? Well, the best way is to give them.
Right.
Pick a few people to give them, and people will just automatically return the favor. You don't even have to ask in most cases. So if recruiting, and that is sort of frontal lobe for so many centers, recruiting and retention, and LinkedIn can play a really big role in both of those things.
Now, let's talk a little bit about the different things that show up in your profile. So I'm just thinking to myself, because you're right, when you go into LinkedIn, you find out everything about that person. So like I teach at a college, I have, 4 different companies, including a puppy business, and all of those things show up on LinkedIn. Now, of course, you go there for a different reason perhaps, but you learn much more about that person. And as I'm listening to you, I'm thinking this is a good way to kind of watch the people that we're recruiting also.
Is your puppy business on your LinkedIn profile?
It is. It's linked to the LinkedIn.
And see, I would look at that first because I'm a dog freak.
Yeah.
And that's a connection point.
That's right.
And I say to people, include your not only your professional posts, but things that are important to you socially.
Yeah.
And
Because
that's a connection point.
That's right.
I'm going to start a conversation by saying, what kind of dog do you have?
Right. Absolutely. Yeah, and then pictures are really a very important part about that. We always when we're posting, we always try to post. It's easy with puppies, a little less easy when we're talking about surgery, about regulatory compliance.
But even photos of ambulatory surgery centers, operating rooms, equipment. Any post with a visual is 5 times more likely to be shared or clicked on than not. So video, everybody stops and watch video. If you have a message, include a cell phone video. It doesn't need to be professionally developed. In fact, people really like that sort of rough, natural feel of a cell phone video right now. It's very in vogue and accepted. So if you have a visual, pictures are really important. And for your profile, you should have an updated profile picture. It should be professional.
I know they're taking them here today. I'm going to get a new one done. Yeah.
Right. I hope everybody's getting their picture taken. And then you have this banner behind your picture, which is another place for you to have a visual. So you can either have your center's logo or a picture of your center. Sometimes it's a word cloud of things that are relevant to your career or your role in the center. Anything that sort of underscores what you do. In mine, it's a stack of newspapers, right? Yeah. I'm in the PR business, so that's how I share that I'm involved in the news.
So let's, for those that do not understand LinkedIn or don't know much about it, we should mention that you have a personal profile, and then you can link yourself to a company. So, for example, each of my companies has a separate page. Which I manage, and then my personal profile is linked to each of those profiles there. And relatively easy to set up. And as a matter of fact, it's automatically set up if you put a company in there. You just need to make sure
you just fill in the blanks.
That's right. And your employees just make sure that they sign up to that.
All the information that you need to put in. And you can have a personal profile even if your center doesn't have a profile.
Correct.
Right?
Correct.
But if it does, make sure you link to it. Link to the association, New Jersey Association page. Certainly, we're very active here. And follow other industry pages. It's such a great way to see what's going on in the industry, exchange helpful information. Yeah, it's invaluable.
And let's talk about groups for a second, because I'm very active in the groups, and we have our own group. We have a Director of Nursing group, which not many people know because we haven't done everything. Maybe I need to speak to you about how we can make these more active. And I think there's so much potential, and I just haven't had necessarily the time. And I got to admit, and for the listeners out there is a bit of a learning curve here. I think I'm learning from yours. It's probably not as bad as I think it is, but then I'm old. You know what I mean? So.
No, don't say that. There's 340,000 groups for medical professionals.
Yeah.
My last count was there's 30 just for ambulatory surgery centers.
Yeah.
And I think, what I tell clients is join a group and watch. Just watch a little bit before you decide to stay and participate. Make sure there's enough robust activity to make it worth your while to sign in. Don't promote. If you promote or start selling, you're going to get kicked out of the group. Yeah. People don't join groups to get sold to. We all get plenty of emails with that, right? Mm-hmm. People join groups to share information. And I will tell you, the groups I'm a member of have become invaluable resources. It's PR people from all over the country. Many are direct competitors, but we share freely.
Right.
And it's a really great space to tap into a collective mindset.
So one of the things I know you talked about is connecting with potential. We talked about how important it is to connect with doctors. They are. We don't generally sell directly to the public. Nope. So we're selling to the doctors who we're trying to recruit to our center. Tell us how you think that your LinkedIn page, their LinkedIn pages out there, our listeners' LinkedIn pages, can help in that recruitment process.
Well, I think people look for a page that's active. Mm-hmm. If you have a page and you haven't posted a status update in 4 months, I'm probably not going to connect with you because I don't really think that you're looking at your page. Right? The more you post and the more status updates that you share, or the more you like other connections posts or comment and say great job or congratulations or this was a good read, the more you show up in feeds.
Yeah.
And when you show up in people's feeds, then your frontal lobe. So when you're making that call to physicians, they're like, oh yeah, I just saw you.
Yeah, right.
And I will tell you, John, I've gotten business that way.
Yeah.
Just by liking somebody's post. I got a call from a woman. She's like, you know what? This isn't about the post, but I saw your name and I have a problem.
Yeah.
And so we talked and they became a client. So the more you participate, the more you work the channel, the more you'll show up in people's feeds, your frontal lobe. And so if you're looking for a job and you're active on LinkedIn, and people see that, they're like, oh, okay, there's a potential candidate, right? If you're a center and your page is active, people are looking for that. They're like, this center's vibrant. There's a lot going on. They care about employees. They're engaged in their community. I want to work for them.
Right. Now, talk a little bit about, there's paid versions too. Now, I've never used the paid version. I have done, and I'll just be honest, I've done the advertisements through LinkedIn. They were never successful.
Why not?
I worked with an advertising company, and I'm not sure the advertising company did a good job. So it's an interesting question. You know, maybe you and I need to talk.
I love sponsored content on LinkedIn. I love it, and I'll tell you why.
Yeah.
First, you reach people that you're not connected to.
Yeah.
So if you want to expand your circle and reach those that don't know you yet, that's the way to do it, number one. Long-form content is another way to do that.
Okay.
And I'll talk to you about that in a second. But you can pay for sponsored content on LinkedIn, whether it's an ad or if it's a small article, and sponsor it so it reaches people outside of your network. You can target by geography. You can target by title. You can target so many ways. Age. I mean, there's so many ways to target. And I love that you could drill down and be that specific. But the other thing is you could pay for that ad by visibility, that they just show up in their feed, or by click.
Yeah.
Now, paying by click, if they click on your ad, if they click to read more of your article, you pay just for that click.
Yeah.
Now, you pay a little bit more, but that to me is a much more qualified.
Because you definitely got,
You've got interaction. They're interested enough to take time to click through and learn more.
And in today's world, we don't have a huge population in our communities of doctors out there. If you're able to target specifically those doctors in your own community or in your catchment area, sounds like a relatively inexpensive way
of
getting
is.
that in. Assuming they're active.
I recommend sponsored content on LinkedIn for all of my clients, actually.
Do you recommend membership? Is membership useful?
I haven't done it. I haven't done it. I don't really speak to it. It's really more, I think, for aggressive recruiting. I know people that do, but that's not something I've been involved in very much.
Is it useful for recruiting like senior leadership in your organization? Like if you're an administrator and you're trying to find a new director of nursing, is LinkedIn a viable option?
People are looking for jobs on LinkedIn. I don't remember the statistic. I think it was 60 million people go on LinkedIn to look for work every week.
Wow. Okay.
That's a lot of people.
Yeah.
You just need one.
That's right.
Right.
That's right. And we're paying an enormous amount of money to recruiters or or even ads. I mean, I'm very frustrated. We don't use the Indeed. Sorry, Indeed, but we don't use it because you get so many responses, and it's just a nightmare to try to go through it. It's too much. Right?
So, I mean, you can target. You can do a sponsored ad on LinkedIn if you want to. But if you have a robust community of connections, and they say more than 500 is the sweet spot.
Yeah.
Because then it says you have 500 plus, right? But between 300 and 500 connections is a good community.
Yeah.
People will share it. Make sure your post is shareable.
Yeah.
Word gets around. And look at the second and third connections of your primary first connections.
Yeah.
You can network in there too.
Move them up to the first. Yeah. This has been great. I've learned so much. Hopefully our audience did too. And it looks like I'll be talking to you about hiring you. Absolutely. So thank you very much. We'll put contact information for you in the show notes. So if anybody wants more information about you and your company,
it's always really nice to talk
to you. Thank you so much.
Thanks.
With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our Administrator Boot Camp and the Director of Nursing Boot Camp, and in 2023, the Business Office Manager Boot Camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central Patron Program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com, or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information.
Our next interview was with Ron Capello with Infinia Group. His speech was titled Future Ready ASC Branding, Marketing, and Business Development.
I'm here at the 14th Annual New Jersey State Association meeting. It's May of 2024. I'm at the Palace at Somerset Park, and this is the annual meeting. And we have an opportunity during these conferences to meet all kinds of great speakers, and I'm here with Ron Capello. Ron and I actually know each other. We met a while ago through a mutual friend, and he actually hasn't spoken yet, but he'll be speaking later on today about future-ready ASC branding, marketing, and business development. Ron, why don't you introduce yourself?
Well, thank you very much. It's good to be with you today. This is my second speech of talking to the association, and I'm very pleased to be here. I've been in the business of brand marketing and growth consulting for about 21 years in my own firm, and about 8 before then. So I'm dating myself a bit, unfortunately. But with that experience comes hopefully a little bit of wisdom that I could share today with those attending the session. And the purpose of the session is to really, when I talk about being future ready, is to really kind of try to anticipate and help them anticipate the changes coming down the road, not only from a technology standpoint, which I'm not going to opine on too much, but really from kind of the expectation of what the consumer, which a patient is at the end of the day, what is a consumer going to expect from the standpoint of an experience? And how can you deliver a better experience and do it in a way that doesn't break the bank? And the way I'm going to tell them today and talk about today is that you really, it's a 3-legged stool. One is what I call growth through simplification. And digitization is helping this, but there are many, many things that are just simply too complex for the patient. It makes them frustrated. So even before they get to your ASC, they're kind of like cranky. And not only are they cranky, but they're nervous about what's going to happen.
Right.
So the degree to which someone, or hopefully more than that one someone in the ASC, can work on simplifying processes and making it a smoother pathway towards getting into the ASC, getting the procedure done, doing the follow-up. So simplification is one leg of the stool. The other leg of the stool is detail and attention to detail. Because that's what people remember. Right? It's those small, kind, incidental things that we're all capable of doing, but because we're very busy or pressured, or in an ASC environment, you're asked to do 10 things when you really should be doing 4 things type of thing. So attention to detail, which starts again understanding that the path to getting a procedure done at an ASC really starts when the consumer, the patient, is getting ready to leave in the morning.
Yeah.
Driving, coming, parking, coming in. So at every step of the way, and I'm going to talk about this later, is there are what are called moments of truth. And that was quoted by Jan Carlson, who was the former CEO of SAS Airlines, Scandinavian Airlines. And he was charged with turning the airline around. And what he was able to convince all of the people at SAS is that an airline trip doesn't start when you board the plane. It starts when you make the reservation, when you figure out how to get to the airport, when you go to the counter and get your boarding pass, as you pass through, when you get on board, when you get your bag. So I'm going to encourage the participants today to think about what are the moments of truth within an experience for an ASC that they can improve, that they can touch on. And it might even be just something like a better good morning when they answer the phone, or to check in with someone. And then the final thing is that you take the simplification process, you really focus on details, and then you try to craft an experience that's either distinct to your ASC or distinctive to the participant, to the patient of the ASC, for something memorable. And I'll tell you a story that I'm going to tell them. Some time ago, about 8 years ago, I fractured my shoulder and I went to hospital for special surgery to have it done, outpatient basis. My wife and I go in, I have a cup of coffee, Starbucks, and of course the woman says, I have to take your coffee. And that's fine. So she takes my coffee, checks us in. I go through the procedure. I come out of anesthesia, get dressed. We're gonna leave. My wife and I are gonna leave, and that same woman comes back with that coffee that had been microwaved.
Oh wow!
And hands it to me.
Yeah.
Now
that's a detail.
I don't remember.
You remember the coffee?
I don't remember the surgery.
Yeah.
But I remember that kindness. And that attention to detail.
Yeah.
And I think we all do. When we step back in our lives, we remember those things.
Yeah.
And to do it isn't hard. You don't have to hire another person. You don't have to hire a consulting firm. You just have to think about what kind of kindness can I extend today.
Yeah.
So that's in large part what we're going to talk about.
Yeah, it's interesting. I have a minor story myself. When I was running a surgery center, we had started giving our patients Stelladora cookies after the procedure. And it wasn't because we thought, well, these are like really high quality cookies or great cookies. It's just that, they were available at a good price from the vendor, and we thought, well, we'll try it for a while. And then, at that time, this was years ago, I was the chief financial officer, and said, well, are we paying all this money for Stelladora cookies? Well, so we went with cheaper stuff, and suddenly we realized that it was part of our brand, that people came expecting those Stelladora cookies. Right. And to your point, people didn't take kindly to a knockoff cookie at that point.
Right.
And we went back to that. And we never, we actually didn't even know it was part of our brand.
Right.
It's a fascinating topic. Yeah. Ron, what strikes me as I'm listening to you is that, I'm passionate about quality improvement. Mm-hmm. And of course, when we talk about quality improvement, we're not talking about the little things like you've described. And please don't take that wrong.
No.
We're worried about the patient,
of course,
surviving the procedure, not having any complications and things like that. Mm-hmm. But you bring up such a fascinating topic, is that some of our quality improvement programs could probably really be enhanced by a little bit more attention to details there, especially as we move into OAS caps, where they're going to be, judged against a much, 36 questions as opposed to often, 5 or 10 questions that we used to ask.
And I don't, to your point, I don't think the two are mutually exclusive.
I agree. Totally agree. But we don't often include that level of detail in our quality improvement program.
And then another item that we're going to address is AI, which has a lot of people worried.
Yeah.
They're nervous. And I have a slide in my presentation that says, fear not, because I look at AI not as artificial intelligence, but augmented insights. And augmented insights requires machine learning capabilities, but it also has an equal, if not bigger, human factor, right? At the end of the day, a human being's going to interact with a human being.
Yeah.
Will technology continue to enable? Yes. Will technology hopefully take off the plate some of the more rote and mundane things? Yes, we hope so, and that should be welcomed by most people in an ASC. But I really think focusing on the human factors and the relational aspect of business, even if it's just for that one procedure, it will stick in people's minds. And that's what I mean by being able to market and grow without having to spend a lot of money. It's really just being conscious of what you're doing and focusing on people. And I spoke about this last year, which I called the golden rule of business development, which is follow the golden rule.
Yeah.
And everything will follow from that.
Right.
Treat others the way you want to be treated, maybe even elevated given the circumstance of someone going through a surgery, and everything will take care of itself after that. So,
what do you think are a good starting point for this?
It's a great question, and I can tell you quickly.
Sure.
As you know, in any organization, but particularly a smaller business like an ASC, the initiative has to come from the physicians, from the doctors, from the administrators, and as the saying goes, "Physician, heal thyself." Physicians could learn to perhaps be a little more inclusive with their staff, a little bit more polite with their staff, and tell the staff that they embrace this idea, which should appeal to them, because we're not talking about spending a lot more money.
Right. That's what's a good
it's
point.
like doc.
Well, maybe the Stellador cookies are more
maybe
expensive.
the cookies.
But again, the scheme of things,
we'll get the doc to do that.
Yeah.
But if leadership embraces, then everybody on the staff understands that it's something real.
Yeah.
If leadership doesn't, they're skeptical, and they should be skeptical.
Right.
It's like, well, it's a lot of yapping, but really no action. But
to your point and to your story, the extra energy that they put into the microwave to make you a happy customer, there was really no money involved in that.
None. Zero. Zero. And the extra effort of, if you see something in the parking lot, either pick it up or call the facilities manager and ask them to make sure it's clean. If you have magazines in your waiting room,
they're 20 years old.
Don't do that. You're better off not having any.
Right. Yeah.
But if they're current, I think people like that and appreciate it. If someone is offered a glass of water or something comforting when they come in, but all just little incidents.
Yeah.
I remember, as an aside, the late Doris Duke, who was a fantastic philanthropist. I think lived to be 100 or 101. She was being interviewed by Charlie Rose once, and he was trying to get her to kind of talk about her philosophy of life and other things. And she said, Charlie, my philosophy is treat everybody with kindness, whether it's the doorman, whether it's the sanitation worker. And this was an enormously wealthy person, like all the privilege in the world, but just don't ignore people. Just treat them with kindness, and that's always stuck with me. And I think as we lead more frenetic lives and all the poison of social media and other things, particularly for younger people who are now starting their own families and other things, I think social media has done a lot of harm in making more people who are more transactionally oriented than they are relationally oriented. In other words, we just do this transaction, we're done, you go on your way, I go on my way. It's like, whoa, wait a minute. You've run a center before. even today, with social media and everything, word of mouth is still the very best. Because when there's a need, the first thing and they've done study, the first thing that person does is call family members and say, "Who did you go to?"
They're not looking that up on the internet.
They're not looking at WebMD.
They might eventually, but initially that first impression
call is call dad, call mom, call your uncle had a similar procedure. Let's find out who he used. Yeah. So even as we barrel along the digital highway, that human element is still quite important. It might take a little bit of different, form in the way of its involvement, but it's still central. Yeah.
Well, and I definitely think that, to your point, this is a good time to be talking about that, because when OAS CAPS comes on board in January of 2025, there's going to be a lot more information, experiential information, coming from those patients about things we've never asked. We've always focused on the actual care itself instead of the way you've necessarily been treated throughout the whole process.
The other thing about being future ready, if I love history and I read a lot about history, but if you look at history, as Warren Buffett says, it doesn't repeat itself, but it does rhyme. So we have to be, in the ASC world, aware of what is likely to happen. Mm-hmm. If we think there's not going to be downward pressure on prices, we're kidding ourselves. Yeah. Right? All right, so if that's the case, instead of panicking, what initiative can you take to kind of anticipate that without diminishing quality, without diminishing the experience? Digitization helps that. Yeah. Other more modern forms of communication helps that. But we really need to be, more conscious and aware, not of just what we're doing, which requires a tremendous amount of concentration in each individual locale of an ASC, but really kind of the broader trends of really, talk to your staff about demographic trends. Mm-hmm. Do you really, and then B, the differences between, boomers, Gen Z, and millennials, their approach to healthcare and the consumption of healthcare is different.
Right.
Are we aware of that? When we're talking to a boomer, should we talk to them this way? Et cetera. So,
and have we talked to our staff about the different ways that we educate them?
And I think the staff would actually find that interesting.
Right.
And I think the staff would also say, I never thought of it that way, but the way I approach, if I'm a mom, the way I approach healthcare is different than my daughter's approach to healthcare with my grandchild.
Yeah.
Right. So it's again, little things add up.
Yeah. Right.
They simply add up, and the more that we can be aware of them, the more that we can embrace them, the more that leadership can foster that esprit de corps that we really want to be. Of course, we want great outcomes, and of course, we want our patients to do well. But that, I would say, that's about 50 to 60% of the equation. Yeah. You still have 40 to 50% of the equation that what I call, I actually just wrote an article. It hasn't been distributed yet, but I said the title is, "Why are the soft things so hard in the ASC world?" Mm-hmm. Why are the intangible things that, everyone says, "Oh, well, the HR people, that department, I'm not quite sure what they do. What do we need an HR department for?"
Yeah.
They deal with all that soft stuff. Well, that soft stuff rolls up into a center's culture, rolls up into that center's employee retention rates,
right,
satisfaction rates, and everything. So it does matter.
Oh, absolutely. And that's a very good point, too, is that while you've been talking about the customer being the patient here, we have many other customers, including the employees.
You've got your referral sources, right? You've got your staff and employees. You've got the doctors. Yeah. You've got the community at large. You've got the payer community, right?
Yeah, don't forget all of their.
I mean, do the payers see your center as a really high quality plan? Kind of playing it down the middle.
Yeah, and they're getting that information from the patients or from their subscribers.
Yeah,
exactly. Yeah. This has been great. Thank you so much, Ron. I appreciate your time.
Thank you. As you can tell, I really enjoy this, and I hope the session today they'll like it as well.
I'm sure they will.
Thanks so much.
Thanks.
And last, but certainly not least, I had an opportunity to interview my dear friend Amanda Penrod. Amanda is the president of RFX Solutions, and they provide an all-in-one healthcare regulatory compliance software solution for ambulatory surgery centers. And indeed, RFX is our back-office solution for our surgery centers, at least those that choose to use it. And Amanda and I have known each other for a number of years. We've talked a lot, but I've never actually had her on the podcast. And for her presentation at this conference, she spoke about credentialing compliance. So let's listen to that interview.
So I'm here at the 14th Annual New Jersey State Association meeting at the Palace at Somerset Park in New Jersey. And I'm here with my dear, dear friend, Amanda Penrod. Amanda, you and I met a couple years ago and immediately connected. We're both small business owners, and though your business is a lot bigger than mine now, but we have a lot in common, and we've been in this industry for a long time. And you tell us a little bit about your company and you.
Well, John, I really appreciate it. Thank you.
Sure.
And I'm excited to be here again. And yes, so I'm CEO and founder of RFX Solutions. So we're regulatory compliance software, and been in the industry for about 25 years now myself, but excited to be here today and really talk on the subject of credentialing and that here in New Jersey and with these teams and administrators here. So.
And we met because, for those that are not aware, RFX is our back office system, for many of our clients. You mentioned you're in regulatory compliance. Of course, we're the nation's leading firm in regulatory compliance oversight. So that's how we met up, and that's where we found a solution. And one of the things that we all know has happened recently is credentialing's gone through some changes. There was a company out there that Silver Sheets that did a great job and then went out of business in December, and you kind of picked up the bandwagon from them, didn't you? You created a system to be able to port information over to your system, and but I think the more important conversation here is about credentialing and how you do it right and how you make sure that it's really all about the documentation, isn't it? So and that's what your session was on. So your session was titled Understanding and Avoiding Common Pitfalls of Credentialing. So talk a little bit about what, by the way, you haven't actually done the speech yet as we're recording this.
I have not actually talked yet, but I'm very excited. So yes, a lot of it about documentation, but something else very passionate that I'm very passionate about, as well as the company, and then what I'm going to talk about today is really what drives us. And while the documentation is very important, I'm going to talk a lot about the true purpose behind it, because
that's a good point. Yeah.
People are constantly going, okay, I've got to do this to pass my survey. But at the end of the day, it's really about patient safety and having quality surgeons and that in our centers. And so we're going to talk, when I talk about those common pitfalls, I want to give them more of that why behind the what of what we're doing. And so obviously they're going to get educated in terms of, different components and that of, but I'm also going to focus on that risk and their responsibility. So.
Right, and indeed, that's something that's near and dear to my heart. We have a full day. Those of you that did not know, many of our listeners attended our January credentialing and peer review conference, and that is still available on ASC-Central.com if anybody's interested. But it was one of our most popular conferences. As a matter of fact, if I looked at the data, it's probably our most popular conference ever, simply because this is an area that every center has a problem. Almost every center is going to have some type of citation. But Amanda, you said something so important, and I'm on the legal side sometimes. I do expert witnessing for organizations that have gotten into trouble or been sued as a result of a malpractice suit that the plaintiff's attorney is saying you shouldn't have credentialed this person. So that's the crux of it. Talk a little bit about how you not doing a good job of credentialing can end up with some bad providers.
Well, the biggest thing, and so kind of two-pronged here a little bit. One, it's a very different. It's not let me just say this, it's not a difficult paper process. It's just a very tedious, time-consuming. There's, as you know, there's a lot of components with that, which is why then, for us with RFX, being able to leverage software and tracking mechanisms, some of those automations and that around also making sure, in the sanctions or OIG licensure and continuously monitoring it. But even a step forward into this is the ability to be able to review and know what's happening real time, but also as they're getting ready to look at taking the credentialing, which is the verification process, and to actually privilege them to be able to do privileges, it's reviewing all that information to determine, is this person trained? Right. Some of the examples that I'm going to talk about today, there's obviously the big case in Texas with Dr. Death. I'm going to do a video on that because I want them to stop and think with all the growth that we have in ASCs, more specialties coming in. But on top of that, another example I'm going to give them is talking about a particular organization a couple of years ago who had an ENT who wanted to go into oculoplastics and really never had training in it. But here they're at an ASC and it's a paper process. It's easy for these things to slip through the cracks. Right. And we just think, service, and I want to provide another opportunity for revenue, or they're getting some pressure. Mm-hmm. But at the end of the day, do they really have that training? And for us, it's the education piece and then giving them the tools so they really can verify and make sure that happens. But I'm going to talk a lot about that with them today and what that means.
Well, you bring up a very important point, too. You and I are administrator types, right? We do not have the skills. We're smart people. Well, you're smart. I'm not. But
no, we're both smart people. Very smart people.
But
we're not clinical.
That's exactly right.
Neither you or I mean, we've got operational backgrounds.
Yeah.
I mean, very strong business acumen, but I'm not a clinician by background.
I can't tell whether Dr. Death was a good doctor or not until the lawsuits came.
Correct.
And that's where and your point is so well taken, is that many of us, I was involved in credentialing, you were involved in credentialing,
Absolutely.
But we didn't make that final decision. Our job was to vet the information and make sure that and we always had to bring the medical director into it, or specialty people into it. And that goes for even people that are lower, because we always use a lot of administrative people to do some of that paperwork. But you can't stop there. You can't just do that and then hand it to the board at the board meeting. It's got to go through a real vetting process.
And there's so much truth in what you're also with. We hand off and we have expectations, even our credentialing specialists. I know I had one that was full-time, or we're bringing in paperwork from a CBO.
Yeah.
We really have to stop and go, okay, I'm responsible for this due diligence, but then I'm also responsible for where are my red flags, where are my problems, what am I, looking at in terms of are there inconsistencies, are there gaps in it, how do I strengthen that, and then as I'm passing that packet forward, making sure that I'm identifying this so it also doesn't get missed to that medical director or, to the committees that are vetting this out before we sign off to say, you know what, this person can come in here to do the procedures. And when we see some of these other things happen in the industry, it often is just lack of time. Sometimes it's just lack of knowledge. Right. Or we're just thinking we're just checking boxes and we're doing this because the paperwork is to meet credentialing, for accreditation or survey. And we actually hear that a lot from clients are like, well, I have to do this because the surveyor expects it. And it's,
and I'm going to get cited if I don't do it right.
And while it's the truth that, yes, we need that but why is the surveyor? Why are accrediting bodies looking at it? And it truly is for patient safety and quality of care.
Right.
And it's just helping to shift that mindset.
You bring up a very important point. You're talking about CBOs, and I have a pet peeve about a lot of CBOs. As a surveyor, I can't tell you a number of times I've come in and the administrator said to me, oh, don't worry, paperwork's perfect because the CBO took care of it. And then, first of all, immediately my guard is up because I know that they often... Yeah. Well, the problem is you're not actually outsourcing any of the decision making. They're basically gathering the information, sending it back to you. And again, this is not something you take directly from the CVO and then hand to the board. Somebody's got to look at that information and make a determination, because they're not going to tell. They're going to gather the information. If there's something that's suspicious in there, they might have flagged it for you, but they're not making the ultimate decision. So the CVO is only a processing organization.
Yeah, and because just industry as a whole, I think there's a lot of work to be done, in helping to educate. That we really have to start taking those extra steps. And again, with all the growth that's going on in the ASC, and now we have more, cardio that's going, and we've added, shoulders for, totals, etc. These are more complicated procedures, even though we're able to start to do them safer and better than what we've done in the past. we're going to be doing more and more of this in that environment. And so we really have to educate a lot more on really why we're doing it and that purpose, and helping empower them with the tools and better tracking systems and technology to manage that process.
Now, this is a very paperwork-intensive process. There's a lot of information to gather, and it doesn't need to be like you and I, as administrators, we always had people that did the work behind, but we managed that process. And again, even if you're using a CVO, and by the way, Amanda, as you know, even with your great software, all you're doing is don't mean to say it that way, but your software gathers the information, stores the information, but you still have to do something with it.
No, that's absolutely. Right. It's even if we're using, whether it's a CVO, whether you're using technology, the onus of the due diligence still belongs to that administrator, and then ultimately to those decision-making individuals on, your medical exec committees, your committees, however that's structured in your governing body, and medical director. So, the work is the decision-making work doesn't rest in any of those other components.
You did mention the podcast, Dr. Death, and I believe there's a television series now. Is it on Netflix or something like that? I really highly recommend anybody that's an administrator, director of nursing, and even your credentialing coordinator, not only go to our conference, but listen to that. First of all, it is entertaining, but it is frightening. I didn't walk away from that feeling comfortable. I felt like, boy, that's my responsibility.
So today you'll appreciate they're actually going to get to watch the trailer for 2 minutes.
Are they?
Yes, they are. And because I think it's important, and it's not to dramatize, it's to help them realize that these incidents and issues, and this is not isolated to this.
Right.
We've had other, the Putnam Medical Center in West Virginia, that's been about 20 years ago. That was a major one. Put an organization. We've got narcotic. We had the plastics who, that just happened here, recently in the last couple of years. And the situation with the wife was never even trained. We're seeing these type of incidences and things that happen. And I, fully anticipate that, if we don't put these better processes and educate more inside our ASCs, we'll continue to see that climb, because they understand that there's even more opportunity to manipulate those systems, coming in there. And so it's just helping them. So today that's going to be part of that education. So
at least it'll be slightly entertaining. Well,
yes, it'll be a little bit, but it is still frightening. But I want them to understand it's more than credentialing, or not credentialing, but more than the accreditation types of processes. That there's a bigger why behind what we're doing.
And negligent credentialing is that legal term that they use right now for organizations that have been sued by the plaintiff's attorney, making an allegation that the doctor should never have been credentialed at your organization, and that is that's becoming a more common part of those malpractice cases. So that's one of the you're right. You got to do the right thing, but that's one of the other things that is happening.
The risk that we're carrying.
That's your risk, and we know that if we're not doing a good vetting, you're going to have a problem. And you also mentioned something that I kind of touched on this. One thing that I've been worrying about, we're finding doctors, because the technology is changing the types of procedures we're doing, different ways of doing these procedures. And we're a surgery center. We don't have a training program. We don't have mentoring programs. We could develop them, but do we really want to get into that? So that's what makes it so important that we're vetting them through other sources, such as identifying that the hospital is granted them privileges, going to their peers to get references indicating that they've been trained, showing educational, not only the education and training, but that they've done these procedures somewhere else. So that should be an important part of that process too.
And absolutely. And, for many of them, as in the example I gave, with that ENT, it's, for them in that particular center, all of a sudden they start questioning that training. And we need to be. And if we don't have verifiable proof that this training has existed, whether it's through, to your point, hospital privileges, through peer references or any formalized training programs, then that's a red flag. And granting them, puts those patients at risk. And then ultimately, to your point, from a liability standpoint, that center's at risk too. Because if we're granting those privileges, we're saying that we've vetted them and that we know that they're qualified to do this. And we feel comfortable saying that the majority of instances, patients are going to get a quality outcome. And, that puts us at a huge risk when things do go wrong. So.
And let's just finish by kind of touching on peer review for a minute, because I think that's one of those areas.
That's a whole big topic,
is. Yes. We can't talk about it here in depth, but that, after you've initially credentialed somebody, you've got to track it. You got to look at that quality improvement data and really determine whether you've got a problem or not.
Absolutely.
And not be afraid to address it.
Absolutely, and that is one of the actually one of my common pitfalls. I don't dive very deep in it because that's a whole, as you and I both know, session on that. But talk to them about the fact that a lot of times, those KPIs and those quality metrics, because it's depending on the credentialing or the privileging period of 2 or 3 years, we're having to maintain that data for the entire rolling time, and then aggregating it to understand what type of quality provider, are they in that organization. And too many times either we don't want to address it, or we've had, individuals leave and we don't have good tracking mechanisms around it. And so we end up with gaps there too.
Yeah. And that's something that, I listen to our listeners periodically. We get calls, and this seems to be a problem that is increasing, or maybe we're more cognizant of it, that people are coming to me and saying, I've got a provider that we really don't want here anymore. And of course, the first thing I say is, why is that provider there?
Yes.
Didn't you know something beforehand? Didn't you suspect that? And, usually it's process that was probably rushed through very quickly. Yep. And it's so much more difficult to get somebody out afterwards that you don't want there. Yep. And it just gets to the heart of doing good credentialing in the first place, tracking them as they're going along, and then either, working with them to fix their skills if they're, not up there, or, kind of encouraging them to find another place to go and work.
Yes.
So. Yeah. Amanda, it's been a pleasure as always talking to you. Just so everybody knows, more to come between Amanda and our company. We got a lot of exciting things going on.
I really enjoy working with you guys.
Thank you.
Yeah.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ASCPodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.